Hello. Are you able to hear me? Yes. Okay,
Yes.
perfect. Good afternoon and welcome. This is the special Hoffman-Ratson Grand Rounds lectureship that was established in 2005 by the grateful trainees of Dr. Thomas Hoffman and Dr. Kenneth Ratson, who headed the infectious disease training programs at the University of Miami and Jackson Memorial Hospital and Mount Sinai Hospital on Miami Beach in the 1970s and forward from then. Dr. Thomas Hoffman received his medical degree from the University of Pennsylvania before completing a fellowship in ID at the University of Rochester and was chief of the infectious disease at from the 1970s up until 1998. And Dr. Kenneth Ratson completed his medical degree at Harvard Medical School before residency training at Columbia Presbyterian and ID fellowship at New England Medical Center in Boston. Dr. Ratson was chief of ID at the Miami VA in 1972 before moving to Mount Sinai, where he served as the chief of ID division there until June of 2020. Dr. Hoffman and Dr. Ratson's expertise was widely recognized in the community, and they're both set high standards for their trainees. We are honored to have Dr. Ken Ratson with us here today. And I'll say he's a brilliant and elegant clinician whose legacy of rigorous clinical thinking and his scholarly approach has impacted infectious disease trainees over many years, and many of the faculty and practicing community physicians here in infectious disease in South Florida. This visiting lectureship was established to bring physicians from around the country to Medical School to honor the tradition of clinician scholarship set by these outstanding leaders. And it is appropriate that we have Dr. Valerie Vaughn, an expert in antimicrobial stewardship and medical decision making, with us here today for the Hoffman-Ratson Grand Rounds. So the chief resident will now introduce Dr. Vaughn.
Good afternoon. It is my pleasure to introduce today's Grand Round speaker, Dr. Valerie Vaughn, who's joining us from the University of Utah. Dr. Vaughn is a tenured associate professor of internal medicine, a presidential endowed chair, and the director of clinical research for the Department of Internal Medicine. She is a nationally recognized leader in hospital medicine whose work has focused on reducing medical error and improving antibiotic stewardship, and has been supported by organizations such as the Agency for Healthcare Research and Quality, the Center for Disease Control and Prevention, and the National Academy of Medicine. Her work has been published in multiple leading journals, including JAMA and Annals of Internal Medicine. And we're delighted to welcome Dr. Vaughn today.
Thank you so much, and thank you for having me here today. It's an honor to be able to present to you all and to get to spend some time with Dr. Ratson as well, so appreciate the honor. I have one disclosure to make before we get started, and that's just that I am on the advisory board for Danaher, which makes biomarkers related to pneumonia. But if you ask me about them, I will be telling you not to use them. So I don't think that's a massive disclosure. My second disclosure is you may all be somewhat confused because I was invited here by the infectious disease division, but I am not, in fact, an infectious disease physician. I am married to one, I'm friends with one, I work with one, but I am a hospital medicine physician. And what I'm going to talk about today is really how we think about the common diseases, and specifically pneumonia, that hospitalists treat every day, and kind of my perspective on great care for pneumonia and on antibiotic and diagnostic stewardship for pneumonia. So this is really focused on the hospitalist perspective. And I'll touch a little bit today about the guidelines that just came out this summer, which were very interesting and very controversial. I can give a little bit of insight into some of the processes that went on there. But before I get started, I like to kick things off with a case, which I think is always a good way to start any good conversation. So let's talk about a common case that someone like me, a hospitalist, might see, and I'm sure all the learners in the back of the room have maybe admitted even a case like this today to your hospital. So an 80-year-old woman who has a history of dementia and presents for altered mental status to the emergency department. She comes in alone from her nursing home. She's unable to provide any history. There's no real reports in your medical record about what her traditional status is like or what she's usually like, although it seems like potentially this altered mental status is a change from her baseline. Physical exam, not super helpful. Her vital signs are stable. She's only oriented ×1. And her physical exam isn't very easy. As you try to listen to her lungs, she's kind of talking continuously, so you can't really get a good insight into what her lungs sound like. And her laboratory findings are equally nonspecific. White blood cell count is 10,000, so not really high, but not really low. And before you've even had a chance to think about her, somebody has, of course, obtained a urinalysis, which is widely positive, but also is filled with squamous cells. The culture is pending. And if this were a board exam, you'd get some sort of chest x-ray that looks like this, and you'd be like, this is great. She's got a pneumonia. I know what to treat her for. But instead, you get something that looks like this, and the radiologist tells you, poor positioning and effort, cannot rule out underlying infection. You also wonder why she has so many lines and tubes across her chest. This is clearly not her real x-ray. But the point is, this is what real medicine is like, the uncertainty here. Have any of you admitted a case that looks something like this? I can't see hands raised online, but here in person, we have almost every hand in the room raised. So I'm going to ask you, for the people online, think about this in your head, and in real life, I'm actually going to have you raise your hands to say, what's your next step? Would you do supportive care, but get a chest CT to evaluate for pneumonia? Would you do supportive care and empirically give her vancomycin? I mean, she is coming from a nursing home. Supportive care and ceftriaxone, thinking, hey, the ceftriaxone would cover a UTI if she has a UTI, but would also cover pneumonia. Would you make really good friends with your night team by saying, hey, I know I'm going off service. Could you check on this patient in a couple of hours? Or would you give up because medicine was never supposed to be this hard? So how many people would choose A? We've got a couple of hands in the room. B, we've got some vancomycin users in the back. Ceftriaxone, C. That's the most so far. How about asking the night team to check back in? Okay, everyone is already afraid of their night team, so good to know how the culture is here. And then who's giving up? Okay, we have a couple of people who have walked out and they're done with residency. So, I'm not here to give you the right answer for this. I'm just here to ask the tough questions and say that we don't actually necessarily have the answers for the tough questions, but I'll walk through how I would think about this and talk about some of the general principles I think about when it comes to pneumonia. So my goal today is to really talk about diagnosing and specifically trying to avoid overdiagnosing pneumonia. Talk about diagnostic stewardship, or this idea of using the right test for the right patients at the right time, and specifically how that applies to pneumonia. And then talk about antibiotic stewardship, which I've thought a lot about as applies to pneumonia, and I'm sure you guys have all heard a lot about as well, since there's really robust antibiotic stewardship going on here. So let's start by talking about diagnosing and avoiding overdiagnosing pneumonia. And to do that, I want to ask maybe the most difficult question that you will be asked, which is, what is pneumonia? And I ask this because if you get 10 smart people in the room and ask them this question, you will probably get 10 different answers. And the thing is, there's not really a great way of figuring out what is pneumonia. And in fact, it's really a clinical diagnosis. What you're looking for is a combination of clinical signs and symptoms and radiographic findings. And we actually had a definition that is relatively similar to what's used in clinical trials. This was approved by the National Endorsement Agency for CMS as a way to look and diagnose pneumonia. But it's basically this idea that someone should have both signs and symptoms, preferably 2 or more. People don't often present with a single sign, plus radiographic criteria. And, traditionally we use chest x-ray to diagnose pneumonia. Nowadays, our most recent data shows that up to 60% of patients hospitalized with pneumonia are getting a CT scan as well. So there's a lot of diagnosis that is happening with chest CTs. And then our most recent guidelines that actually just came out of the American Thoracic Society say that lung ultrasound can also be used to diagnose pneumonia. So radiographic criteria, but plus signs or symptoms. So the question is, what sign or symptom from this list actually has good sensitivity and specificity? And the answer is absolutely none of them. This is a little bit small to see on the big screen, but up here, if you look at the sensitivity and specificity, you obviously had trade-offs. There are some that are sensitive, like cough, right? Most people with pneumonia have a cough, But pneumonia can cause, or cough can be caused by a million other things. So it's not very specific for pneumonia. If you go down the list, some of your auscultatory findings, specifically things like agophony, have higher specificity, so does tachypnea. But again, none of these have a great sensitivity or specificity, and it's really the combination of findings that you're supposed to have. And what this results in is that there's a whole bunch of things that we treat as pneumonia that ultimately end up being something else, right? Who here has worked at the VA? I think that's right, you guys. I feel like every patient that comes into the VA, we give diuretics, antibiotics, and steroids to, because it's just impossible to know which one did they have. Was it heart failure? Was it pneumonia? Or was it a COPD exacerbation? So it's just a very, very hard diagnosis to actually wrap our heads around. And one thing I can say is that there is at least a subset of patients who it's pretty obvious do not have pneumonia that we end up treating for pneumonia. So this is a paper that we published a couple of years ago in JAMA Internal Medicine, where we applied those prior criteria to patients retrospectively, where we had data abstractors actually collect records from the medical record and look at signs, symptoms, chest imaging, CT findings. And we looked at almost 17,000 patients. And what we found is that there were 12% of patients that had either no symptoms of pneumonia whatsoever. So they were treated mostly because they had a chest x-ray finding that was like, cannot rule out pneumonia, but then they had no pulmonary symptoms at all. Or the opposite, they had a cough, but they had a negative imaging. And the patients at highest risk might be the ones that you would suspect. It's just like the patient that I showed a case on. So patients who had an older age, patients with dementia, patients with altered mental status. If people have heard of like asymptomatic bacteriuria and how those patients are often treated for urinary tract infection, it's the same risk factors. So this is the same kind of idea, which is that when it's hard, because it's a confusing situation, we often blame an infection. And that could be pneumonia, or that could be urinary tract infection. And so we see that in this population as well. And we saw when we looked at this and we adjusted for reason for treatment, that full course antibiotic treatment was associated with more antibiotic-associated adverse events. So patients were more likely to have harm and no other outcomes. So things like length of stay, things like readmission, mortality was better with antibiotic treatment in these patients. And these were just the cases that everyone agreed were not pneumonia. So 12% is the low-hanging fruit. There was another third of patients in there where one person said, I don't think they have pneumonia, and another person said they did. We didn't include those patients because, like I said, there's not a real great gold standard for diagnosing pneumonia. So my first pearl, and I'm going to have a few pearls as take-homes for the residents in the room, but is that patients with pneumonia really should have both some sort of sign and symptom of pneumonia and imaging findings. And if they don't, they could still have pneumonia, but I think it's really important for us to think about looking for something else. Do they have a pulmonary embolism that's causing their symptoms? Do they have heart failure? So really, if someone doesn't fit the criteria, it should pique your interest to look for something else as an alternative cause, which might end up being better for the patient if you get the diagnosis right when you start. So diagnosis is one piece of it. Let's switch gears and talk a little bit about diagnostic stewardship for pneumonia. And so diagnostic stewardship, I defined this earlier when I introduced this, but diagnostic stewardship is really the concept of having the right test for the right patient. And I think this segues really well with a lot of things that we naturally do as clinicians, which is we really think about what are the tests that are high value, that are going to improve care for our patients, and that are not going to be harmful. And so this is a really important concept for pneumonia. And this has actually changed quite significantly from when I started training. So I think it's helpful when you're thinking about what is the highest impact and the most value to think about what the most common cause of pneumonia is. So I'm going to pick on our residents in here. Can anybody tell me what the most common cause of pneumonia is? I heard strep. That's all I heard is strep. Okay. So strep is what I was taught as well. if you look at the best study that we have to date of the common causes of pneumonia, the most common cause is we have no idea. So that's about 2/3. So 2/3 is we have no idea. After we have no idea, the most common identified cause is actually viruses. And in this case, 1 in 5 patients with pneumonia they found had a viral pathogen. And then you can see that strep is in fact the most common cause of bacterial pneumonia at about 5%. But I think this is helpful because when I was taught, strep was the number 1, 2, and 3 that we were always concerned about. But now, as our diagnostics have changed over time, I think we understand more that there's probably more going on than just strep. And we should be thinking about some of those other things as well. And so when I talk about pneumonia, one of the questions is, well, what do I mean when I say viral pneumonia? Because, that has changed as well over time. The study I showed you on the prior slide, if you look at coronavirus, they said 2%, but that was before COVID-19 happened. The study is from 2015, and obviously COVID is now one of our biggest causes of pneumonia, especially in patients that get hospitalized. And so this is national data from Epic Cosmos, which is the warehouse for national Epic Cosmos data. And you can kind of see what things have looked like since 2022 to 2025. So the blue there are the spikes for COVID. The orange is spikes for influenza. And then the gray is the smaller spikes down there for RSV. So you can see that those are the top 3 most common viruses. We've looked at this at Utah because Cosmos doesn't report out the rest of the viruses. And at our hospital, we have a little bit more of a closer mix between COVID and influenza, but then 51% is what I call the rest of the viruses. So what I mean by that is coronavirus, rhinovirus, and the hard thing about that adenovirus is there's always the question of, wait, is that what's causing the pneumonia? Or did we just happen to detect it at the same time as someone came in with symptoms of pneumonia? And so that's, I think, a question that still is being tried to be answered. Okay, so that's what causes pneumonia. And I think that's helpful to keep in mind when we think about the update to the guidelines that happened in 2019 about what diagnostic tests we should be ordering for people who come in with pneumonia. So the first is gram stain and respiratory culture. This used to be something that we got all the time, and I know because we'd always order it and it would never get obtained and I'd never get the results, and then we'd have to chase down the respiratory therapist who would also not be able to get it. And so, or if we did get it, it would be spit in a cup, which was not helpful. And eventually IDSA and ATS said, you know what, this is usually not helpful. And as a matter of fact, if you're thinking about the most common bacterial pathogen for patients with CAP, it's strep, as you guys mentioned, which we're going to be treating anyway. So there's no reason to actually do this, to chase around the respiratory culture, if you're just going to be treating for strep anyway. And so they said, you really don't need to get this unless the person has severe pneumonia or unless they have risk factors and you're empirically treating them for MRSA or Pseudomonas. So that was the first change. The second one was they actually said the exact same thing about blood cultures for the exact same reason, which is that for most of the time, this isn't going to change your management. Now, it's interesting because we still get blood cultures, and at the most recent data I looked at nationally, 95% of patients with pneumonia, and that's largely driven by a lot of our sepsis metrics and the fact that blood cultures are often obtained before we even think about, does this patient have pneumonia or is it another infection that we're thinking about? So I've seen changes in practice in number 1 up here, but not so much in number 2. And then they actually don't recommend routinely testing for Legionella either, except for the same thing, severe pneumonia or epidemiological factors. And in this case, it's because it's become relatively rare without being one of those things, severe CAP or epidemiological factors. And then not routinely testing for pneumococcal antigen either, except in severe pneumonia. So the summary of all of this is basically they recommend no diagnostic testing for patients who are hospitalized with pneumonia unless they have severe pneumonia or a risk factor for a more resistant pathogen. And the reason is because it doesn't change management, because you're either treating, I don't know, you're treating virus or you're treating strep, and those things, all the management doesn't really change. based off of this type of diagnostic testing. And we looked at this actually in our hospital right after these guidelines came out to say, is this true that in fact the diagnostic testing doesn't change any management? And we found that only 1 out of 89 patients who had a respiratory culture would it change management. None of the blood cultures would have changed management. None of the Legionella or strep pneumo antigen tests would have changed management. So again, kind of consistent that at least for non-severe CAP, those that you're not treating with kind of broader spectrum antibiotics, that really a lot of this diagnostic testing isn't that helpful for guiding management. Now, my husband is an epidemiologist, and he would love you to get the diagnostic testing so that he can track over time what patients have, but for the individual patient in front of you, it's not really as helpful. So let's go back to talking about viral testing. Should we be getting viral testing? This is actually a question I forgot to ask this morning. Do you guys use extended panel respiratory viral testing here? I see a lot of head nodding in the positive. So, and that's consistent. So this is data over time looking at what viral diagnostic tests are being used in patients hospitalized with pneumonia. And this is from 4 million patients across 615 hospitals in Premier. And what you'd see if you went back further is that in the past, basically every influenza season, you'd get people testing for influenza, but there was no other viral testing really happening. And then in 2020, this thing called COVID happened. I don't know if any of you remember that. But at around that time, there was a huge increase in people getting COVID-19 single tests. So that's the purple line there. But then kind of in the years that followed, this interesting thing happened where there started being these different ways of diagnosing viral infections. And the most common ones that I know of are kind of the quad panel, which tests for the 2 influenzas plus RSV and COVID. That's the blue line there, kind of showing that over time people have started using the quad panel. And then there are like the multiplex BioFire panels that test for like everything known to mankind. And those are the green ones there. And you'll see that those have also increased over time. We at the University of Utah use the green. It looks like that's what you guys are using as well. But the point is we're now testing for viruses in about 80% of patients with pneumonia. And that is vastly different from practice pre-COVID. And a lot of that is due to new developments in diagnostic testing. Now, it's interesting because the American Thoracic Society actually says we shouldn't be doing that. And they say that we should only be getting kind of these more extended panels in patients with severe pneumonia or those that are immune compromised. And you'll see that this actually differs from what the Infectious Disease Society of America says. I was on this pathway, and we talked about this question quite a bit. And the answer we came down to is something that you should think about with every diagnostic test, which is really if it will change management. And the problem here is that for the most part, it does not change management. At least that's what we see. Now, whether it should change management is a question I'll get to later. But the answer is if you get a patient and you get these tests are expensive, so multi-$100 test, you swab someone's nose, and it comes back and it says that they have adenovirus, are you going to stop antibiotics? Is that going to change your practice? And for the most part, it does not change practice. And so that's why we left it as if you would actually change your management based off of the results of the test, you should get it. But otherwise, the quad panel, which has influenza, COVID, those are the things where you might actually change management, right? Because there's treatment for influenza, there's treatment for COVID. So that's why there's kind of a little bit of a difference between the recommendations between the societies. And it's probably good to get the quad test. Whether you should get something broader probably depends on what you're going to do with that information. And this is the small details. So we also say consider discontinuing antibiotic therapy if viral diagnostics are positive. Procal is less than 0.25. White blood cell count is less than 10,000, and low suspicion for bacterial co-infection. We probably argued over every single word in that sentence. So it's obviously not something based on a lot of data, but mostly based off of expert opinion. So pearl number 2, for most patients hospitalized with pneumonia, beyond COVID-19 and influenza testing, which would change management, you really don't need etiologic workup for most of them. And that's mostly because the etiologic workup does not change management. So if you think about the potential cost savings from not getting blood cultures, which are not comfortable to get, or not getting, sputum culture, which rarely actually result anyway, this could be a major change in practice. So we talked about the first two, diagnosing and diagnostic stewardship, which I feel like are kind of under talked about in pneumonia. And let's get into the antibiotic stewardship piece of it, which I think you guys are all doing really well on. So hopefully this will be a little bit of a summary. So I'm going to talk about empiric therapy, antibiotic duration, a little side note to talk about diagnostic momentum and return to our case. And then I'll talk about viral pneumonia, which I've alluded to already, but has been a major area of controversy in this past year. So I'll talk about that a little bit more. So let's talk about antibiotic stewardship and why we care. The reason I care about antibiotic stewardship is less to do with antibiotic resistance, which I think is important, but is hard for me to kind of think about broadly, and more to do about the potential harm from antibiotic overuse for the patients in front of me. This study came out right when I was kind of really starting to get into research, and it showed that 20% of patients hospitalized and treated with an antibiotic have an adverse drug event or side effect from that antibiotic within 30 days. And this ranges from, GI upset to acute kidney injury to more major things like C. difficile. So these antibiotics are not without harm, and it makes sense if someone has a bad infection that they need it anyway. But a lot of the time, I think we default to, well, let's give them an antibiotic just in case, just to be on the safe side. And it turns out that antibiotics are not in and of themselves safe. So when we're saying just to be on the safe side, we're probably doing more harm to our patients than good. So if anything, we should be thinking twice about antibiotics. And when it comes to side effects in themselves, there's less kind of comparative effectiveness research. So head-to-head research about different regimens, different durations. Some of the early work we did showed that every extra day of antibiotics you give to someone with pneumonia increases the odds of them having an adverse drug event by about 5%. The absolute magnitude of that is relatively small, though. But when we're talking about some of these other antibiotics like anti-MRSA therapy, specifically vancomycin, there's been some really good kind of retrospective causal inference work that has shown that empiric anti-MRSA therapy increases the risk of death, kidney injury, C. diff, VRE, and secondary gram-negative rod infections. So I think specifically thinking about early empiric therapy and making sure we get that right is really important. And then there's the long-term microbiome impact, which this is kind of a hot field right now, and I feel like we're only going to see this grow over time. But antibiotics definitely have an impact on the microbiome that lives within us. And then there's the antibiotic resistance. And I said that's not the reason I got into stewardship, but I think it is important to think about because it's important not just to society as a whole, but also to our individual patients, because every round of antibiotics that they get increases the risk that the next time that antibiotic's not going to work for them. So these are why I got into antibiotic stewardship. But I think it's important to think about how we think about or adverse events and outcomes and how patients think about it. So we did this really cool study last year where we actually created a rank list of all potential outcomes a patient could have from pneumonia, all the way from death to being alive with no side effects and no residual symptoms, 14 days after hospitalization, and then everything in between. And we actually surveyed both clinicians and patients, and we asked them to put them in order of what is the best to the worst outcome. And what we found was really interesting. So on the left is the clinician ranking, on the right is the patient ranking, and these are the ones that they shared in common. So everybody thought that not being hospitalized, having no residual symptoms and no side effects was the best, and that being dead was the worst. So that obviously makes sense. I'm glad we were all in agreement about that. But in between, it was interesting. So clinicians didn't care what the side effect was. They just cared about the impact on activities of daily living. So these three categories were all ranked the same by clinicians. And then the next three were all ranked the same by clinicians. And the big thing was really that the top three didn't cause an impact on activities of daily living, and the bottom three did. It made people need extra care, or it impacted their general ability to conduct life. In contrast, patients separated these. So they actually thought, and what I'll show here, what I have boxed is the ones that are related to continued continued symptoms from the pneumonia. And what patients thought was it was actually better to have continued symptoms from pneumonia than to have new side effects from their antibiotics. So the after being alive and well, the next best case would be alive and well, but still with a residual cough or residual shortness of breath from their pneumonia. They then thought it was worse to have experienced nausea or vomiting or diarrhea either during or after hospitalization. And I find that really interesting because as a hospitalist, the order I have for antiemetics is actually something automatically put into my order set. And I actually never even know if patients necessarily have these symptoms unless it goes beyond that and they need like a secondary line of medication. So one of the things that patients actually care about, I actually don't know that much about as I'm taking care of them. So I thought this was really interesting. And I think it should make us think twice about antibiotic side effects and how we think about these because it clearly matters to our patients. Okay, so empiric therapy. I will touch on this only briefly, but basically this is what the guidelines say, and they separate whether people should be getting anti-MRSA or anti-pseudomonal therapy based off of tiers. So the top row here is for non-severe pneumonia, which for the most part is what I take care of, and the bottom row is for severe pneumonia. And basically, the idea is that if someone has grown MRSA or Pseudomonas before, you should empirically cover for that regardless. That is the number one risk factor for them having it again. And whether it's non-severe or severe, you should be treating them with either something to cover MRSA or something to cover Pseudomonas, depending on what they've had in the past. But then if you look at all of the other risk factors, that's when the recommendations for empiric coverage differ. So if someone has had a recent hospitalization with IV antibiotics, then they should only be empirically treated if they have severe infection. If they have non-severe infection, this is that case we talked about earlier with the diagnostic stewardship, you should get diagnostic testing for MRSA and Pseudomonas, so blood culture, sputum culture, but you shouldn't be starting it empirically. You should only be starting it if it comes back positive. And so that kind of differs from based on severity. And what about locally validated risk factors? So there's been one of the recommendations in there was that you should be thinking about locally validated risk factors and deciding whether someone should be treated for MRSA as Pseudomonas. And there are a lot of them that have been published out there. One of ours from, I'm from the University of Utah, from our colleagues down the street at Intermountain, is the DRIP score that has been published on a lot. And the hard thing about scores like these is things that have been validated in one healthcare system don't necessarily transfer to other health systems. And we actually, so same state, same patient population, we tried to replicate the DRIP score within our health system and found basically that it didn't work very well. The area under the curve was 0.76, which was far less than was published in the original validation of it. And the only things that predicted MRSA or Pseudomonas was a history of MRSA or Pseudomonas, kind of like was said in the guidelines already. So this is one of the scores that a lot of people use. When we revalidated it, it didn't work well in our health system. So we really only focus on the main risk factor of a prior MRSA or prior Pseudomonas. And then the reason I'm talking about this so much is that this anti-MRSA therapy issue is actually probably the most important thing when it comes to pneumonia stewardship because it has the best data really showing that it causes harm. And again, just that same paper from a colleague of mine at the University of Utah, Barb Jones, who showed that unnecessary MRSA therapy is associated with higher mortality and a whole risk of other things. I'll also point out here, one of the things that we can also do is convert people from IV to oral. This is something that if you're thinking about trying to convince the C-suite that something matters, this is nursing time too, right? Having your nurse go in and have to hang another bag of antibiotics, having to keep that IV going in a patient when maybe it's already blown. Maybe you should just switch to oral antibiotics instead. And there have been multiple studies out there that show that outcomes are similar if you switch early to oral therapy. Okay, so switching gears a little bit to talk about duration, which is something that my work is focused on a lot more over time, starting first with trying to decide what is an appropriate duration, and then second, trying to get people to actually follow that. I worked with a collaborative of 69 hospitals in Michigan called the Michigan Hospital Medicine Safety Consortium, which is where a lot of the work came from looking at duration. And most of the analyses I'm going to show you are from 2017 to 2020. And basically, we were able to collect data from the medical record because of funding from Blue Cross and Blue Shield of Michigan, our major insurance company. And that allowed us to both do chart review, but also have meetings where we came together to share best practices and implement pay-for-performance metrics, where we got hospitals on board with stewardship priorities by giving them quality targets to meet. And we did it for both pneumonia and UTI, although obviously I'm just going to talk about the pneumonia work today. Our 3 pillars for improvement, which I think are important to almost everything we do in life, is that first and foremost, you really need data to know where you are compared to your peers, how you're doing, and where you should focus on. And so that was kind of the first step in working with these 69 hospitals, is let's get some data, let's show how you're doing compared to other hospitals that you work with, and make sure it's data that you believe. And so data that's accurate and adjusted for the patient population that you care for. And then let's see who's doing the best and have them share what they're doing and why it's working for them. And then pay for performance. Nothing talks like money. And so, like I said, we had performance metrics for hospitals, and they got money from Blue Cross Blue Shield of Michigan if they met them. They got money withheld if they did not meet them. And what we found is that actually we were able to really improve antibiotic duration over time. So this is the percentage of patients who should get a 5-day antibiotic duration, who actually got a 5-day duration. So what you'll see is when we started at the beginning, it was only about 20% of patients got a 5-day duration when they should have. And by the end, it was almost up to 40%. That's what the blue line in the middle shows, is all kind of the average across the collaborative. You can see that each of the individual lines is a single hospital, and there were some that had massive improvement. I mean, that hospital that went to from 20 to 80% was quite striking, but almost all hospitals improved over time. And what we found as this happened is actually that our composite adverse event dropped over time from about 20% to about 17%. And that was pretty standard across all of the hospitals. The numbers kind of got small for some of the hospitals, but generally hospitals saw an improvement in outcomes as they reduced antibiotic duration. And our composite outcome here was readmission, mortality, physician-documented adverse events, and patient-reported adverse events. So we called patients after hospitalization and asked them about side effects. That's where the majority of the improvement was seen. So, I mean, I bring this again to myself as a hospitalist who doesn't necessarily follow these patients after the hospital. So I don't know if they're going home and they're having nausea or diarrhea or upset stomach. But if you call them, you find out that you are, and you can improve that. You can reduce that by reducing antibiotic duration. And then after that was done, so like I said, this work is showing through 2020. So we've continued to improve since that time. But there's a trial that came out that said maybe you don't even need 5 days of antibiotics. And this was published in Lancet in 2021. They took non-ICU hospitalized patients with pneumonia. They used a similar definition that we did, which is fever, signs and symptoms of pneumonia, and a pulmonary infiltrate. They required people to get 3 days of beta-lactam therapy and clinically stabilized. So I'll show those stability criteria here. That means they had to be normotensive, afebrile, have a normal respiratory rate, be off oxygen, and have a normal mental status by day 3 of hospitalization. And then they randomized them to get either 5 more days of oral therapy or to get 5 days of placebo. And what they found actually was no statistical difference in any outcome, although there was a 9% increase in cure in the short duration group, and adverse events were the same, mortality was the same. So either no difference in outcomes or maybe even improved outcomes with the 3-day duration versus 8-day. And what this trial triggered was a change in the guidelines. So these are the guidelines that came out in 2025. I actually authored the section on duration. And what we said was we really need to be doing a shorter duration of therapy for patients who can get by with it. So for adult inpatients with non-severe CAP who reach clinical stability, we suggest less than 5 days with a minimum of 3 days rather than 5 or more. I'm sorry that's worded so strangely. There's a lot of reasons that went into that. But in other words, if your patient is better by day 3 of hospitalization or by day 3 of treatment, they really can stop therapy. I do want to point out, and this is buried in the text of the guidelines, so I'm going to unbury it for you here, that the 3-day criteria for this trial don't apply to all of your patients. And I think that's really important. I don't want you to go out from here and say, Dr. Vaughn said treat all of my patients with 3 days of antibiotics. So these are the stability criteria. And what this means is really, it's most patients that maybe should have never been hospitalized in the first place, maybe at a community hospital where they admit patients with a curb 65 of 0 or 1. But it's really, you have to be ready to be discharged by day 3 of hospitalization, right? Because if a patient meets all these criteria by day 3, I'm not sure who's going to let you keep them in the hospital, right? They're off oxygen and they're stable. We actually applied the criteria to that database of hospitals that I work with in Michigan and said, how many of them would meet the clinical trial eligibility for a 3-day duration? And the answer was 10%. So 10% is really low, right? Most of them, I want to point out, were ineligible due to comorbidities. So we don't actually know, and in fact, there's like so little data on patients with comorbidities because clinical trials just routinely exclude them all. It's really annoying. But basically, anybody with lung disease, anyone with immune suppression, anyone who's ever been with any medical condition before, it seems like. So a lot of patients got excluded just right off the bat because of comorbidities. A smaller number actually were excluded because they weren't stable by day 3. So it actually turns out most patients stabilize relatively quickly. And so what I kind of take home from this, we emulated a target trial with our population of 55,000 patients and showed that mortality, readmission, urgent visit, and C. difficile were all the same with 3 days versus longer duration if the patient was eligible for the trial. And as you might suspect, not very many people are using 3-day duration yet. You can see that, so the trial was published in 2021, and you see a little bump there in 2021, and then a slight bigger bump in 2022. And right now, we actually found out that about 20% of our hospitals are recommending a 3-day duration. So people are moving towards this, but the numbers are still really small. So I would say my take home for 3-day duration is that we don't actually know that longer durations are necessary for that 90% of patients that were excluded from the study. So I kind of think about it more in terms of how's the patient in front of me doing it. If they are stable and looking better, I actually tend to go toward the 3-day duration. But if they're not stable yet, if they're still looking bad, if there's anything that gives me a little bit of worry, I aim for that 5-day duration where there's a lot more data around the safety of a 5-day duration. And then just to talk very briefly about what we're doing in Utah to show that we've been kind of doing all the things I've been talking about today, we've been doing at the University of Utah since 2021. So we have no blood cultures, no strep pneumo urine antigen. We use locally validated risk factors for antibiotic resistance, which is a history of MRSA and a history of Pseudomonas. Our default antibiotic duration is 3 days. The antibiotics fall off after that. And we actually use amoxicillin as a step-down drug. So people get 1 day of ceftriaxone, and then on day 2, they're automatically switched to amoxicillin, which stops on day 3. So this is actually what that order set looks like. You can see ceftriaxone followed by 2 days of amoxicillin. We don't prescribe azithromycin, which is a whole nother conversation I can get into later if anyone wants to. Because of that, we test for Legionella. And then we use procalcitonin, which again could be an entire other lecture as to whether that's appropriate or not. But this is the way that we do it. And what we've seen over time is we've been able to vastly decrease antibiotic duration. So the blue bars there are post-implementation of this order set. And what you can see is that now about 15% of our patients get a 3-day duration, about 20% get a 4-day duration, another 20% get 5, and then it really tails off after that. So we've been able to really decrease our antibiotic duration, and our outcomes have remained stable in our patients. So pearl number 3, antibiotic duration of 3 days for some patients, but 5 days for the rest. And I'd say probably right now I'm using about 50-50. 50% of my patients get 3 days and maybe 50% of them get 5 days. And how you draw that line really should be based on a little bit of clinical nuance for the patient in front of you. And then if you actually look, I'll just show this one time, which is like, where is the extra duration coming from? The top graph up here shows what the antibiotic duration after hospital discharge should be for patients. And you see that the vast majority of patients actually need no additional antibiotics at discharge. And then it's 1, 2, or 3 days that come after that. But in real life, what people are prescribed at discharge is 5, 7, or 10 days, right? So not really based on any evidence. It's just that we like numbers that are days of the week or number of fingers or toes. So 5, 7, or 10 all sound good. So discharge is kind of this interesting place where antibiotic stewardship programs often don't focus on it. We may not even be talking about it on rounds. And so it's just this decision that we make kind of spontaneously. And what ends up happening is that a lot of our excess antibiotic duration happens at the point of discharge, and it's kind of been a blind spot for us. So the next kind of piece under antibiotic stewardship that I want to talk about is diagnostic momentum. So let's go back to that original patient that we had. So this is the 80-year-old with dementia, altered mental status, and a positive urine culture, and maybe a positive chest x-ray. It was really hard to tell. But let's say that, she comes in, she gets better on the antibiotics and fluids that were started. Her procalcitonin comes back negative. Her mental status clears. She denies urinary or pulmonary symptoms. And you found out that she was started on Ambien just prior to admission. Now suddenly you have more information. And in fact, she turns to you and she says, "Hey, doctor, I never want that Ambien medicine again. It made me feel awful the second I took it." And what happens is that over time, we often end up making decisions under incredible diagnostic uncertainty. And when people first come in, the risk might be higher and the diagnostic certainty is lower just because you have less information. And over time, what happens is the risk goes down as you know that the patient is getting better, and your certainty goes up as you start to get more diagnostic or historical information. But what happens in reality is that this thing called diagnostic momentum happens. And Crossgary wrote about this as one of the biases in medicine way back in 2002. And he said at that point, a diagnosis made, even under great uncertainty, is rarely overturned. And in fact, what happens that's really interesting is when clinicians share diagnoses with each other, you kind of assume that your colleague is more certain than they were. So the ED clinician says, "Hey, I'm admitting this patient with pneumonia." You're like, "Okay, this patient has pneumonia." If you ask the ED clinician, they're like, "I don't know what they have. I just needed to tell the hospitalist something." And then the hospitalist tells their colleague, "Hey, I'm treating this patient for pneumonia." They also weren't that certain, but you're like, "Oh, I can't overturn my colleague. They're so smart, and what would they think if I changed their diagnosis?" So there's this thing that happens where we start assuming that the person before us knew more than they did, and it's really hard to stop these diagnoses. So one of the pearls that I want you to take, and I don't have a lot of data around this, but this is just something I know to be true, which is that we really need to reconsider diagnoses as new information arises. This should happen during the handoff from the emergency department. It should happen between handoff from hospitalist to hospitalist, and it 100% should happen at discharge home. So we might have admitted that veteran and treated them with Lasix, antibiotics, and steroids, but by the time of discharge, we should know whether they had heart failure, pneumonia, or a COPD exacerbation, and we should change our diagnosis to say that. That way, the next time they come in, it also helps the next clinician who might have a little bit more information about how to treat them. And then just in the last few minutes, I will touch briefly on viral pneumonia. And the reason is that, so in May 2025, the guidelines from the American Thoracic Society came out, and we sought to address what we should do with viral pneumonia. Should we be giving antibiotics to patients who are now getting all of these viral diagnostic tests? And they have adenovirus, they have COVID, they have influenza, and they have a pulmonary infiltrate. And you might notice that this guideline says American Thoracic Society. The prior guideline said American Thoracic Society and Infectious Disease Society of America. So this is the question that made that long collaboration between the two societies fall apart, and the Infectious Disease Society removed their name from the guideline over this controversy. And basically what IDSA says is that thank you, AI, no empiric antibiotics should be given unless you suspect a bacterial infection. And American Thoracic Society says, for inpatients and outpatients with comorbidities, we suggest prescribing empiric antibiotics to patients with pneumonia and a viral diagnosis. So I'll let you kind of make your decision about this. This has been really interesting to be a part of this. There are very strong opinions on both sides, And I'm here to tell you there's actually very little data. This is something where we've submitted already a couple of grants trying to answer this question. If you guys have access to data that can help us answer this question, please do so. I'd love to see it. Since the guidelines were released, there have already been 2 studies that have come out that I'll just touch on briefly. One of these was of 1,000 hospitals in Premier. It looked at patients with COVID and emulated a target trial for antibiotic treatment versus no antibiotic treatment for COVID. And they found that about 30% of patients hospitalized with COVID and having some sort of diagnostic code for pneumonia received antibiotics, and outcomes were either absolutely the same or maybe a little bit worse if you were treated with antibiotics. And that remained true even when looking at 2023 data. And I think maybe, I'm not sure antibiotics really harm patients, although it could. There could be some residual confounding here, but there was definitely no strong evidence that antibiotics are helpful in these patients, and they may even be harmful. And then this paper actually came out just within the last month. You can see it's still in kind of like the draft form online. They tried to do the same thing, but looked at viruses beyond COVID. They looked at about almost 7,000 patients across 5 hospitals with possible CAP. So patients had to have an X-ray, they had to have symptoms of CAP, they had to have a respiratory virus, and they looked at the impact of antibiotics. Their main analysis was looking at 0 to 2 days of antibiotics versus 5 to 7. They did subsequent sensitivities where they just looked at 0 days, so no antibiotics. They found that about 70% of patients were prescribed antibiotics, and they found no significant differences in length of stay, ICU admission, and hospital mortality or 30-day hospital-free days. So again, no strong evidence here that antibiotics are helpful for these patients with viral pneumonia. So I would say, I'm not going to go out on a limb and say don't treat any viral pneumonia with antibiotics, but I will say the preponderance of evidence for COVID is definitely that we shouldn't be treating these patients with antibiotics. For any of you that lived through the pandemic and took care of these patients, you know that COVID can cause really bad lung disease, can cause ARDS, can cause sepsis, can cause damage. For the other patients, I think, again, I go back to the clinical nuance. There are some patients that I will give antibiotics to, and there are many patients that I will not give antibiotics to. And I really like practicing watchful waiting in some of these cases, right? So how do they do with a day of providing them oxygen, providing them fluids, trying to make them feel better? Does that help? So in summary, I think as clinicians, we really play a key role in both diagnostic and antibiotic stewardship. I think we can help fight antibiotic resistance, but also improve outcomes for the patients we take care of. And particularly the outcomes important to them, because side effects do matter to our patients, as some of our work has shown. And it can help us be cost and value conscious, especially in today's current environment where we're really trying to think about appropriate use of the limited resources we have. And the pearls, patients with pneumonia should have both signs and symptoms and imaging findings of pneumonia. Beyond COVID and influenza testing, most non-severe pneumonia doesn't need etiologic workup. Really ask yourself, will it change management? At the University of Utah, we've had success with safely treating most patients with ceftriaxone to a MOX for 3 days, but really think about trying to shorten that duration. Most of the excess duration happens at discharge. Think about diagnostic momentum, not just for pneumonia, but for all the patients you take care of. So as new information comes up, reconsider those diagnoses and think about whether you need to change your differential diagnosis. And don't treat COVID pneumonia with antibiotics. And I look forward to vigorous debates about the rest of pneumonia with the rest of you guys. But hopefully I've left a little bit of time for questions. Thanks.
Thank you so much, Dr. Vaughn. I'm pitch hitting for Dr. Weiss. He's at a satellite clinic, so sorry he couldn't make it. And I think it was great that we had ID and hospitals collaborating. And as I was going through as a GI doc, I think of replacing respiratory with stool pathogen panel, which we don't know what to do with. We overtreat diverticulitis and gastronitis with too many antibiotics. I think there's a lot of crossover across a lot of the specialties. So thank you for that great talk. I'll lead off Dr. Doblecki or Dr. Ratson. Do you want to make any initial comments? We have a couple minutes before another group's coming in.
At your institution, do hospitalists take care of all the pneumonia patients? I mean, because the medical care is trending that way.
Yeah, so definitely anyone who's not in the ICU that has pneumonia is being taken care of by a hospitalist, unless we have a specific pulmonary service for our lung transplant patients. So that's kind of a separate group.
And these guidelines pretty much followed by then, because that would have a major impact with
Ye-
antibiotic stewardship.
Yeah. So, I mean, the wonderful thing about stewardship at our hospital, and I can't take credit for this, Emily Spivak, who heads our stewardship program, before I even came, had really made inroads with our hospitalist group. So, in all of our initiatives, we have a hospitalist champion it. So then that hospitalist goes to our divisional group and says, this is what we're doing as a group now. This is the order set we're going to be following, and people change practice. Now, it's not instant. We're not at 100%, right? But we're at 50%. I think probably nuance allows for that variation that comes after that.
Because I can see that change from, 14 days to 3 days at the Michigan study you did. I mean, pharmacists play a big role in making that change. And the medical staff has to buy into that. But they usually do. They usually let the pharmacist make that decision, which has a big impact on shortening duration of therapy.
Yeah, absolutely. So I'll make 2 points. I 100%, I love everything you just said. Pharmacists are integral to this. We're lucky in that we have pharmacists rotating on every single hospital medicine team. And so they're already a part of clinical decision making for us. So it's really helpful for them to be like, hey, the antibiotics are falling off today. Are you okay with that? Or like, hey, we had broadened this patient's antibiotics yesterday, but their cultures have come back negative. Do we want to de-escalate today? And it's really nice to have them there kind of as a second set of eyes reminding us and being part of the stewardship team, the stewardship ethos. And then for the second thing about getting buy-in from the clinicians, I mean, to me, stewardship, so hospitalists are really into value-based care, choosing wisely, and doing what's right for our patients. And I think if you can frame things like stewardship, like diagnostic testing in that lens, it's really helpful for getting them on board. So if we focus too much on like this general concept of antibiotic resistance, that's really hard to get people to buy into. But if it's doing what's right for our patients, improving outcomes, reducing overuse, that's something that I think every doctor wants to do.
We have 30 seconds.
Secondary bacterial infections, how often they occur and how long they occur during the viral pneumonia events?
Yeah, that's a great question. Secondary bacterial infection. The problem is, depending on what study you look at, the answer to that is 0 to 60%. And the reason is that it's dependent on how you answer that question. So the 60%, for example, that comes from people who have looked at patients who are able to give a high quality bacterial sputum. That is not most of the patients that I care for. But if you look at those patients, 60% of them could grow a bacterial pathogen if you use special diagnostic testing. The 0% comes from large studies where you just let people do kind of the standard diagnostic testing, which I've already said you shouldn't be doing any. So if you don't test for it, you're not going to find it. So it's really hard to know the answer to that question because the studies have varied so much. In my clinical practice, what I say is I definitely, whether it's evidence-based or not, agree with like the second sickening sign. So if you have someone who got sick 10 days ago and was starting to get better, and then they got worse again and they're coming in and they test positive for COVID, influenza, something like that, I think probably something happened and they got a secondary infection. And so that person I would treat with antibiotics for sure. But I'd love to see, and we are submitting a trial to answer that question.
So thank you again to Dr. Vaughn. The reminder that CME and MOC are available either in the chat or on the QR code as you go outside. And I saw one slide you referred to yourselves as the U. We think we're the only ones that are the U. And we'll see you next Wednesday, hopefully with the national championship under our belts.